Hello?
Hi, Manuel. Nice to see you.
Likewise. How are you, Kamal? Good?
I'm very well, thank you. And thank you for joining us this evening.
Oh, my pleasure.
Manuel, where are you at the moment in terms of geography?
Oh, geographically, I am the northeast coast of Brazil. My hometown, a place called Bahia.
Ah,
It's
very
like the,
nice, very nice. Because
like the
I know
Caribbean.
you're traveling a lot these days, so that's why I checked. So when were you in India last?
Couple of weeks ago.
Yeah, yeah. So it's really nice the way it's taken off. Hello, Sonia. Sonia's here. I can see.
Hi. Hello, nice to see you.
Yes, nice to
Yeah.
see you too, Sonia. I think Bridge is just coming in. There he is.
Hi, Sonia. Thanks for joining in.
Hi, hello.
Hello. Hi, Manuel. Evening.
Good.
So we all see us in Miami. What do you think?
Sonja, I'm sorry to say, I don't think so.
Hmm.
You can travel as European. I have to quarantine for 14 days. They will give another announce, I think, in September 12 to 15, as they did each 2 months. And subsequently, nothing changed. Absolutely nothing changed. And actually, the Florida now is a hotspot like New York was in the beginning. So I was talking with André Teixeira, and in Orlando, they suspended all the surgeries, all the elective procedures,
Again.
as well as Miami. And things are not getting better. And a lot of young people non-vaccinated, and they never seen so much people on ECMOs.
Yeah, I know. I mean, I was going to go to Sages like right now, and initially I had agreed to it because there was a session on one anastomosis gastric bypass, and I'd accepted it like last year. But in the end, they said the meeting was only going to be face to face. There's no hybrid option, and I had to politely request them that I cannot come. It's just I think it's not a great time to travel around, and things are so fluid everywhere. Then people get stuck. Then you get a positive test, and then you have to stay for 2 weeks, and and I don't have that much leave, to be honest. If I get holed up somewhere, I'll lose all my leave, and I'll then be in a difficult spot. So no, I'm not going to Miami either. But I will be going to Belfast for our OG's meeting. I'm looking forward to that one. Couldn't go to Bomb.
Yeah, just imagine, I have to quarantine, we have to, in Brazil, have to quarantine for 14 days. Then you get to US, then you get COVID, 14 days more. Or even if you're not, you quarantine for 14 days, then you have to another extra week. So it's around 21 days without any earning.
Yeah, and US is quite bad, as you said, with the pandemic at the moment. I think it is quite, quite difficult in the US at the moment.
So Sonja, sorry, no shopping in Miami for you.
Sonia, are you going though?
I have planned to, but we have to see.
Well, good luck and go. And that's all I can say, really. But hopefully next year, I think things will come back to normal-ish. So next year we'll have lots of meetings face to face.
But Kamal, they allowed me to send my presentation recorded for Sages. I just did my presentation today. Yeah.
Okay. Well, 6 weeks ago that wasn't an option. So I told them, I think roughly 2 months ago, I think I said, and they said there's no hybrid option. So I said, fine. Well, in that case, it may not be possible.
And by the way, how much time do you want me to spend on on the presentation?
So Bridge is in charge tonight.
So Manuel, I think it's
Yes.
fairly easygoing. But I was thinking we have you and Mohit presenting, and we have about an hour for the meeting. So about say 20-25 minutes. You think that will be enough?
Okay, and what the level of scariness you want me to achieve?
So
I can reach anyone, any level.
I'm sure you can. The level is quite variable. So we have got quite junior surgical trainees to senior surgical trainees with a lot of interest in bariatric as well as bariatric consultants.
Yeah,
So that's the kind
so
of,
not
it's a bit of a
to
mixed
scare
bag.
them.
No,
Not to scare them at the level that they quit bariatrics.
that's true. Yeah, that'll be helpful.
So Sanja know my weapons. It's just like in bypass. Wow, man. Ooh.
I'm just checking. So I don't see Rupa yet, and I don't see Mohit yet. Are they
Okay.
coming?
I talked with Mohit today. He was quite sure that he was able to make it. If not, just tell me, and I have the presentation ready for you.
Okay. Well, I could wake Mohit up,
Or I can begin, and he can come out later. Up
The
to
only
you.
thing was that, are we sending a reminder from TUGS Lounge? I don't know.
So
if we...
there has been a bit of a technical thing. I tried to, so I sent it about to 60 people, and then Zoom was not allowing me to send any reminders. So I was a bit stuck. Yeah, I tried that a couple of days ago, and same thing happened. Then I tried it yesterday, it was working. So I thought, okay, I'll just send it a couple of hours ago. And then I sent reminders for about 60 people, and then it stopped me from doing it. So yeah, I don't know, there's a bit of a technical glitch there.
Yeah. I mean, I can bring a second computer and have a go with that, but it's a bit late now.
It is, yeah.
I think maybe in the middle of the talk we'll say, well, look, people who want to attend, they will put it in their diary and they will find their Zoom link from the email boxes like I did.
When yeah, I know. Sorry, Kamal. You were the first one to join, register for these meetings. So I couldn't reach to you.
No, I mean, but then I also know, I just registered again the bridge and I just found my link again that way.
Okay,
So,
okay, yeah.
It wasn't an issue really. Rupa is here. Hello, Rupa. You're mute. And I can see Mohit logged in as well.
Excellent, yeah.
Hi, Kamal. Can you hear me?
Yes, we can hear you, Mohit. Can we see you as well, or it's too late in the evening in India?
No, I'm in Barcelona.
So you're in Barcelona. Well, that's a similar time zone.
He's living the good life. He's living the good life.
Indeed, I have to concur with that.
But I can't see myself. Can you see me?
No, we can't see you.
No, we can't. No.
No. Okay. Let me.
So
check.
Mohit, what is happening is that your computer is trying to reach your webcam, and possibly your new webcam is blocking that. So you have to go in video like video wherever, and find the webcam.
Yes.
Real.
While Mohit is doing that, Rupa, hello.
Good.
Hi
You're right,
everyone.
Rupa.
I am. Can you hear me?
Yes, we can hear you loud and clear.
Brilliant.
Yeah.
Now-
Hi, Rupa. I can hear you. Can you see Rupa? I don't know whether
I
can
can
see.
now. Yeah, I can see everyone.
All right. Okay. It's just me. I can't see you, but it's fine.
So, Bridge, at your go, you want me to introduce Mohit and Manuel, and then you will
Please.
introduce Sonia and Rupa.
Yeah.
And who introduces each other? So shall we just shall I say a few lines about you, and then you can.
Yeah. I'm afraid I have lots of lines to say about you, but I'll say a few lines. Yeah.
Just a couple. I think just to keep the decorum, and then people
Yeah.
should presume that we want to be introduced, and not presume that everybody just knows us in the world.
No. Fair enough. Yeah.
So yeah. Right, Bridge.
So what I'll do is I'll stop sharing my screen. Hi, Mohit, I can see you now.
Okay.
You're not in theater, are you?
No.
So Mohit, I'll make you co-host.
Okay.
Then you'll be able to share your screen. Manuel, I've already made you the co-host. Yeah.
Cool.
Okay. Excellent.
So,
So I think it's 8 p.m. So we'll make a start, and I'm sure people will keep joining in. So evening, everybody. I'm Bridge Madhok. Welcome to the 7th TUGS Lounge session, and we'll make a start. We have Professor Mahawar with us, a well-known figure in bariatric fraternity, and he is the chief coordinator for the TUGS, and we are all here together mainly because of his efforts. Kamal, over to you to please introduce our speakers.
yeah, thank you very much, Bridge. And welcome everybody to yet another TUGS Lounge session, again under the stewardship of my good friend and ex-colleague and whatnot, Mr. Bridge Madhok. I'll introduce our speakers first. I'll come back to Bridge's introduction again in a bit. So tonight we've got 2 eminent speakers and 2 eminent panelists. I will introduce the speakers, and then Mr. Madhok will introduce the panelists. So our first speaker, one of the speakers anyway, is Manuel Galvanito. He needs no introduction, I have to say. I've known Manuel and his work for nearly a decade. He's a professor of gastroenterology and surgery at Sri Aurobindo Medical College at Indore, India. I've been to Indore, and then I'll come to that in a second. Affiliated professor of surgery at ABC Medical School of Sao Paulo, Brazil. He's the head of bariatric endoscopy at Mohawk Bariatric and Metabolic Center at Indore, India, and is scientific director at Endovita Institute at Sao Paulo, Brazil, and a director of innovation at International Bariatric Club, Oxford, UK, obviously. Manuel is a legend in the field of bariatric endoscopy. There's hardly a bariatric surgeon in the world who does not know his name. Welcome to TUGS Lounge session, Manuel. Thank you, and we are honored to have you here. Then I come to Mohit Bhandari, who's a great friend of mine. I've known Mohit's work for over a decade as well. Mohit is probably, I think, the highest volume bariatric surgeon in Asia, if not the world. I've been to Mohit's center in Indore. I've also been to the World Consensus Conference at his invitation to New Delhi, which was a mega event. Mohit is the pro-chancellor at the SAMS University in Indore and is the founder, director, and chief surgeon of Mohawk Bariatrics and Robotics in Indore, India. Mohit, what you've established is really a phenomenal journey. And thank you for joining us this evening.
Pleasure.
Bridge Madhok is a great friend of mine, and obviously the TUGS Lounge coordinator, but not only TUGS Lounge coordinator, he's a partner in our whole TUGS journey right from the beginning. We've had numerous phone calls about this and how we develop this platform and everything else. Bridge needs no introduction. He's a consultant at Derby. He's got honorary academic titles at a couple of universities. A great academic, great friend, great surgeon. Over to you, Bridge, to introduce our panelists, please.
Kamal, thank you so much for the kind words. Welcome, Manuel and Mohit. It's an honor to have you. So on the expert panels, we have Sonia Chapeta with us. It's a pleasure and honor to have you, Sonia, with us this evening. Sonia is head of obesity and metabolic surgery unit at a center of excellence in Naples, in Italy. And Sonia, again, is a very well-renowned bariatric surgeon, very keen interest in academics. And she is one of the quite prominent bariatric surgeons seen often a lot of national and international meetings. She has published quite extensively in the field of bariatric surgery and is also a prominent member of several affiliated societies. Welcome, Sonia. It's a pleasure to have you with us today.
Thank you.
And we have my good friend Rupa Sarkar, who was my predecessor at Sunderland as a fellow. Rupa is a consultant bariatric surgeon at Mid York's Hospital. She is again very extensively published extensively in the field of bariatric surgery, and she has also authored a couple of book chapters. Rupa, it's an honor to have you today with us. Thank you so much.
Very much.
So with that, I think we'll make a start. Manuel, you are co-host, and if you want to share your screen, so Manuel is going to talk to us about endoscopic management of complications following sleeve gastrectomy. Following gastric bypass. I'm sorry. So Manuel, over to you. If you can try and share your screen.
Sure. So I do my best when I'm speaking, when I'm telling a history. And first, I wanted to thank you all for this invitation and to share with you guys. And I'm going to share a history on how the bariatric endoscopy had begun. And it begins 20 plus 22, 23 years ago with the gastric bypass. At that time, my dear young friends, maybe you're not, you are not even born, we used to do that open. And what happened is the rate of complications was they're high. Just a second, please. My door is open. I'm just. Sorry for that. So at that time, when those patients complicate, and most of them or have or stenosis or leaks or fistulas, there was a disaster. At that time, those patients, we didn't know. So we take a lot of time to intervene. We escape the 24, 48 hours window. Those patients get inflamed and all the history, you know how it is. 2 months in the ICU, lots of patients dying. And we were doing endoscopy. We were working together with me and my brother-in-law, Mino. For sure, not his cases, but they come from our hospital, a tertiary one. And I said to them, you know, guys, I'm near to the field that you wanted to treat. And the distance that you have to travel is much more than I. And what you're going to do, put a drain and wash, I can do it. I'm just there. And that's how it starts. That's how it starts, my dear friend. And remember that that time was we are doing the notes thing. So we're already perforating stomachs and things like that. So that's how it starts. And we start using off-label the stents because glues, clips, those things that are used to do that they fail. And we start thinking about how's the physiology, the pathophysiology of those leaks, or they are ischemic, or they are caused by hyperpressure from the stenosis. So that's how it all begins. So with no further delay, let me tell you this history. So that's me. That's the team I proudly work with in Brazil right now. That's the bariatric endoscopy team we work, quite some young fellows. And as you already tell them, I'm enjoying Mohit in his beautiful team, in his beautiful city, his awesome facilities in Mohawk. And in Dora, we think we're gonna do a very nice job from now on. This is my disclosure. Disclosures for this presentation, I don't have any. And here we go, if I can. Okay, so bariatric endoscopy in my country is a very mature field. You can see here, now we go to 6 books in Portuguese, there is 3 books in Spanish, 4 books more in English, and around now 800 publications as a Brazilian group over there. And we can go on the most performant procedure and treat complications, leave, bypass, and bends. Let's focus on bypass. And let me tell you something, that bariatric surgery is as safe as lab chole. And I will state that because what you're about to see doesn't contradict that. So bypass complications at the reach of my scope. So what can we treat? And part of this presentation, they are on the library of the American College of Surgery. They have a library, online library in this part of this. So let's start with stenosis. Because why stenosis? Because most of the surgeons, they try to narrow down the anastomosis, the gastrocystinostomy, and sometimes they achieve that. And stenosis, you see here, is the bread and butter of the endoscopies, and most of the times we treat that with CRE. CRE is continuous radial expansion, TTS, through the scope balloons, and you will see here how we do that. We have those types of balloons that go from 6 millimeters to 20 millimeters. They work on water, they are hydrostatic, and you have the special guns and things that you can blow it up and you can dilate it to the lumen you want it to. So you're about to see in how you discover that the patient has stenosis on a bypass. Most of the times on the 3 to 5th week, when you're passing from puree diet to solid food. You can see here a very pinhole orifice that is supposed to be the gastroduodenal ostomy. And what you do, you use the tip of the dilator of the balloon and you pass it there. Most of the time you don't need X-ray. So you just need to know the anatomy and which surgeon did it to position it. And when it passes, you put on the middle, what the radial force is the maximum, and you blow that. So try not to go over to 12 millimeters, because otherwise the surgeon can lose the surgery, the patient can lose the surgery. So if you can, keep it to 12, 10 millimeters, the best. And you see here that even that looks that haven't dilated that much, we can pass an endoscope. And those endoscopes, they are from 8.9 to 9.2 millimeters. So you can see here that you can find your way and you can see the ball. So that's what you do. It's very safe. The possibility of complication here is less than 1%, and most of them are perforations. And even in the perforation, most of the time you can treat that clinically. So that's really bread and butter. But down the road, you can have refractory stenosis, like these ones. So this patient have been dilated 20 times. So what you have to do, we do a stenotomy, and you can see here we are using a hook knife, the same hook knife you guys use it for gallbladders. We have done one for endoscopy. We have IT knife, lots of different knives. So you can really find your way and pass your scope over that. And also you have those kinds of this one that's really, really very difficult and complex. So what I advise is you use the knife and open up to the muscular layer. As you can see here, we are dissecting, exposing the muscular layer so you can cut it open. And also we can put that empirically, local triacenolone, that's a corticoid that can help it be stable. So meaning you can treat, it will be very difficult to give the surgeon back an stenosis. And now we have this new stents, they call tissue opposing stents, called LAMPs. And you can put that, and they are it's very low profile. And those discs that they have anterior and posterior, keep it in place. It can be dilated like this one for 15 to 20 millimeters, and it can stay there for 1 or 2 months, and it will mold the anastomosis around that. So our armamentario is pretty much interesting on dealing with that. And the stenosis rate, it varies a lot. So you guys have learned. So when you change from non-absorbable sutures to absorbable sutures, you almost take all of my job. And I really miss that because I lost a lot of money. I didn't like that. I just didn't like that. But it comes from 10% to less than 1%. Don't like you guys. You don't like us. You see? So the other problem that we can have with bypass is these marginal ulcers. So they appear down the road. If there is like a 1 to 3 months, they're ischemic. So after that, you consider them peptic, but there's not enough acid, I think, to be peptic. So this is a different animal to do that. And those ones we can treat, believe me, the majority of them, they are perforated, terebrated ulcers. That's why they don't heal. And you know that for a fact, because when you intervene and you dismantle the whole bypass to treat this ulcer, what you find on the back of the ulcer, the pancreas, or the liver, or the colon, or the spleen. So we very recently are addressing that by endoscopy, by doing suture. And you can tell me, Manuel, are you crazy? You're suturing an ulcer? Yes, because we think that it's perforated. What we are really doing is what you do from outside. Remember the Graham patch that you do from outside? We are doing inside a mucosal patch. And I will show you some examples. So you can see here, this ulcer is a case of us that we cover And most of them, 90%, they heal. But let me show you Abraham Abudaye doing this also. You can see, to me, this is perforated. And what you see is a wall of, I don't know what, liver, pancreas, you choose. So we're using the suture, and you see here, we go from bottom to top, and we are using the mucosa that is not, how can I say that? That is, it is not fibrotic. So you can go and you're very elastic, you can cover that. You can expect some bleeding because this is a lot of new formed vessels. But if you have the plan on your head, you can go there and you can finish. You see where we are just leaving the needle. Now we are cinching. And let's see how it goes down the road. So that's the follow-up. You can see the sutures, but it's pretty much closer to me. So there's an option for you guys before you go into surgery. The surgery is very painful for that cases. And the other complications I wanted to address with you guys is the rings. So Brazil, my country, for a long time, 90+% of the bypass were banned. And we have done that for almost 20 years. So we had a lot of them. And one of the most frequent complications is the erosion of those rings that is made easy with those kinds of scissors that we have helped develop. So left part of the screen is single channel and right is double channel. So with double channel, we can, even with minimal erosions, we can take it off. So we use like you're doing, we grab and cut. And if you have a very good erosion on the left side, you just cut and remove. And it's pretty much straightforward procedure if you have the right instrument, the right scissor to remove that. I'll leave you with a tip. Every time you remove a ring, go after a gastric fistula because these erosions can cause a gastric fistula. But you can see here, it's pretty much straightforward. I had removed hundreds of those, and we just need a good scissor. Sometimes it's hard to find the good scissor, as Mohit can tell you. Let's go and move forward. The other thing that those rings can do, as you can see here, they can dislodge over the anastomosis, causing an outlet obstruction. The patient will appear to you very, very happy with 17 BMI. Vomiting, not able to eat solid food, but they're happy, but not for the right reason. And that you have to, or they regain weight because they can only drink liquids and they're going to drink a lot of caloric liquid. So the first thing we devise is to use an achalasia balloon. There's a very strong balloon, pneumatic balloon, to blow it off. And you can see here that we had published that. So you can see here from left to right. So you see the drawing, then the balloon inside and the ring being disrupted. And you can see here on the x-ray that we already disrupted. The bad thing about that is these patients, they regain weight because you're going to blow the anastomosis off on that. And you can see here also patients with food intolerance that the ring is kind of there in the place, but the patient cannot eat solid food. And then later with Professor Josenberg in Brazil, we devised another treatment. You can see here that we are putting a stent and do some magic. Some beautiful magic, Sanja. What is outside can we bring inside? Yes, you see, you put this ring in this, and we in the beginning we use the plastic stent. We don't have that anymore. They don't produce that anymore. So see here on the picture, the first picture in the middle, on the upper part, that's almost impossible to pass through. So what you can see here, that I put a stent and you can see the ring from outside. And 2 weeks after, we remove the stent and the ring is there. And as it causes a lot of fibrosis and tissue reaction, so it keeps the anastomosis, and you have 60% of stenosis. That's a good thing because you can calibrate them to what you have done on the beginning from that. The other example here, now we don't have those plastic stents, but we can use the metallic fully covered stent. And a word of caution is remove the stent before 2 weeks. If you let more than that, the fibrosis will close and anastomosis will be very hard to dilate. And the other complication that is those patients that have any problem on the biliary or pancreatic tree. So how to access them? So you can see here the ways we can access. So the most traditional, most old way is by using enteroscopy. On the good old days, we use pediatric colonoscope or the normal enteroscope are very hard to do that. Now with the single balloons and double balloons is 80 to 90% feasible. But once you're there, you're gonna see the papilla like upwards in front of you, and you have very few instruments to do that. So it's feasible, but it's time consuming, and you have to travel a lot and have to be very patient on that. The most appealing, most straightforward approach for us surgeons is to do a laparoscopy, find the stomach, call some guy, hey, here's the stomach, put your scope in, and do your RCP, do your whatever you want. If you think you have to do it again, we leave it like a gastrostomy. So it's straightforward. It's one of the first series published in the world, on the biggest series, and now is that. And you know what? What I see, a lot of people complaining that they can have the gastroenterology to do that, or that. Don't tell me that you don't have that amount of power that you cannot call your GI to do this job. You see, if you do that, then you say that, so your system is pretty much screwed. But it's okay. So this is the way we do, very simple. Open up the stomach, you're seeing here. And once you open the stomach, you can pass a big choker inside, you can pass the scope, wherever you want. So it becomes a normal ERCP for the guy who's doing the endoscopies. As you can see here, we had used in this case, I think a 18 millimeter scope, we pass into the stomach. And you can put some sutures, make it fancy wherever you want, but you know what? It cannot be that fancy. And very recently, also, the GIs come up with using the same stent I have shown you guys, that it's the tissue opposing stent. They can go from the small stomach into the remnant stomach. They leave the stent. They dilate the stent. Sometimes they suture the stent in place not to dislodge, so they can access the stomach and do that. Bad thing is that gonna leave you with a gastric fistula that they say it closed. Up to you to believe or not. But there is some even newer ones that I like most, is that they go on the blind loop of the alimentary limb, and they go from there to the stomach. I think it can close and you can suture there, but the gastric fistula, I don't buy that. But anyways, they are publishing a lot. Let them. And we come to the leaks. Leaks are the worst complication. You can see it can be very controlled and can be disastrous. And even the worst things ever, that is the gastrobronchial fistula, that is the monster, the dragon that we had waken up, especially with what Mohit can tell you about sleeve leaks. Bypass is very hard to have it, but they can happen. So they are low pressure system, as you can see here by this high resolution manometry, the inferior color bar. You see here low pressure is different from the high pressure system from the sleeve. Most of them, good news, they heal up to 30 days. If they don't heal up to 30 days, go there and do something. Or if your patient is such in a bad shape that you have to go and clean up the things there. So clinical management generally works. Traditional therapeutic scope like clips, mesh, they don't work. Now they have the EVAC that's very popular especially in Europe. I have very few experience with that because most of the time I can handle that with stents. And the first thing is dilate first. Doesn't matter if your scope passes to dilated to 20, because you need a low pressure system, this leaks to heal. And let's see how it goes. How about stents? Look at this meta-analysis done, very beautiful meta-analysis done by São Paulo University. 130, 108 patients, bariatric age, bariatric weight, and 76% of overall success rate using any stent by any situation. And you can see here that the leaking time, they are used on acute and early in almost 90% on them. So it worked very well on acute leaks, not on chronic leaks, as you can see here by the losango of the meta-analysis on that one. And bad news, 1.2 stents per patient. So expect that you're gonna have to exchange the stent. Expect the stent can dislodge, that can be blocked, they have some bleeding. So you cannot put the stent and let the patient go home without surveillance. You have to check your patient each week. You have to check on that. You can use two types of stents. Partially covered, they're not gonna dislodge. Or fully covered, that will dislodge. But the partially covered, if you pass 2 to 3 weeks, you might not be able to remove it. So there's a difficult choice. If you have endosurgery, use fully cover and suture. They're going to stay in place because the Achilles tendon is here 30% of migration rate. You already know that. So if you know that, expect that to happen and follow your patient. You're going to have a good success rate. It is like this, done deal. Your patient doesn't feel anything, go there because the stent is not there anymore. The stent has dislodged. They have to feel pain. They have to feel discomfort. This is the job of the stent. As you can see here, the migration rates. So that's how we do. We can see here that you're putting air and the bags are full. So what I do, I use this very sophisticated way to measure. I measure with paperclip. That's the best one to do with that because they are very radial packed. So you can see here the esophagus, the anastomosis, and the bowel. So with that you can see you pass the stent and you can open in a very moderate way. And you can see here, and also with this stent you can see the cause of the leak to stay, that is stenosis with this belly on the middle of the stent. That's what's causing that. And you can see here we test with X-ray and contrast, and you can see here that we are putting a lot of air and air is not passing to the bag. So pretty much is what we can see here. And this patient has already been reoperated, open to treat that before and after. Endoscopy can be used in the worst case scenario. So when you think there's no hope, we can help with hope. Like this patient not eating anything, and it's 5 to 7 days, and we couldn't pass the normal scope, so we passed a pediatric scope, very thin one, and what we can find is a huge ischemia that I'm about to show you. So what to do? So we should leave the patient, put a nasogastric tube, or wait this huge ischemic area to open. So what we did in this case, we put a preventive stent, as you can see here, and it heals. Burst, tell me about the time. I can stop at any moment. So again, we go there, we open, and you can see here, boom, it's there. And then two weeks after, we remove that. Never leave a stent more than 4 weeks. You are looking for trouble. Just don't. And how about this? So I lose my stent. So I send this patient home and the patient didn't contact us. So we can see here, patient was feeling good, no symptoms. Awesome, look what there is the stent is. So I lost the stent, have to go after that. So you know that. So don't go there with a scope. Go with a pediatric colonoscope, go with a longer scope and try to find it. So that's the good thing is most of the times when the stent dislodges, you can see here, it is healed. There's no leak anymore. And then you go there and cross both of your fingers and try to find the stent. And luckily, here it is. And then you fish it and remove it. They always have this lace here. So bring the lace, try to put the scope, it inside the scope so it can form like a duck. I don't know how to tell you that. Wherever. They're going to be narrow that, so it's easier to remove, as you can see here. And then, my friends, we can go in situations like, you can see here, beautiful, no? And how about this one? 5 surgeries. The surgeon declared he can't see anything more. So look at this, you're gonna see that the esophagus is ischemic. And then you got yourself in the cavity. So you don't see nothing. And gladly we have the nasogastric tube. So what we did, we followed the nasogastric tube. And let's see what we found. You can see the cavity here, very small part on the smaller curvature that is attached to this pouch. And let's see, and once we manage ourselves to get inside the bowel, so yes, this is nodes, I know that. So let's see here, we are following, and we are getting to the bowel. And look at the surprise that, oh, where am I? Yeah, the bowel is ischemic. Nice, no? Cool? No cool? Okay. So what we did is that we managed, you can see here very ischemic one. So we managed to pass the wire. And then we put the stent, blah, blah, blah. And the idea is to reconnect. So the patients in the ICU, we basically reconnect the esophagus with the bowel. And it's amazing. It's like you guys when you do a laparostomy. So the tissue come back and go aside. And it's very interesting. And we have around 10 cases of this. So this is the control. And this control, we have done also one before. We did a second look on the bowel to see how ischemic it is. And it was really nice, nice in color, as you can see here. So we didn't pass anything. Now we pass a nasogastric tube. 4 weeks after we check it, he was there. And then time to remove. And let's remove that. So let's remove that. And let's see how it is. I like to show you because you have the opportunity to see how long are those bits that we put inside the patients. So it's very interesting, and you guys are scientists, you can explain to me. Sometimes it epithelializes with esophagus, sometimes epithelializes with stomach mucosa, sometimes epithelializes with bowel mucosa. We never know. That's very interesting to see. But you see that's patient good at home, and there's nothing there. We saw there was something here. We put some contrast, and you see here that there's nothing there. As you can see here, no leaks. And let me end that with this one. How about this one? Patient in laparostomy, in the ICU, they have tried a lot. And this we are passing our scope. We are passing through the anastomosis, as you can see here. We pass anastomosis, we keep going. And Kamal, what I'm about to say to you, I know it's a joke, it's a bad joke, but I see the light. I see the light, you see? I saw the light. The light is there. But why I saw the light? I couldn't pass through. So I got myself, I'm curious. So let's see what's outside. And you see here. And the only thing I didn't put here is a dramatic song. But I can tell you, I didn't feel good, Sonja. I didn't feel good. This is not nice. This is not nice. Not nice. So
Hi, Manuel. I think you're on mute now. But in any case,
yes,
Manuel,
it is not me.
No, I think it is probably us. Manuel, you've got a huge collection of these, and in the interest of time, I think we will move on because what I've seen so far is already fascinating and eye-opening. I just want to.
I'll end that. I'll end that showing you the gastrobronchial leaks that we can also solve by endoscopy. And with that, I leave you with Mohit. And I'm sorry for the time.
No.
And I hope I didn't shock you.
No, you surprised us, but you didn't shock us, Manuel. I'm going to ask, our panelists a question or two, and then I'll ask. In the meantime, Mohit can load his talk.
Yeah.
So, Rupa, maybe if you can come in, we've seen some pretty advanced endoscopic skills here. I think I can do endoscopies, I can do stretching, but that's pretty much it, really. I can put some balloons and take them out. This sort of skill set, do you think surgeons in this country can have them, can aspire to have them, or are we going to have to involve gastroenterologists in this sort of stuff?
Personally, if you ask me, I think surgeons need to be involved in this, and I think we have to incorporate that as part of our training. Unfortunately, I think most of the endoscopies or bariatric endoscopies in this country are done by gastroenterologists so far. But I think we have to set a trend where we as surgeons get trained from an early level, consultant level, and we have to actively get involved in this.
So, I mean, not all bariatric units rely on gastroenterologists group, as you know, because Sunderland, we do our own scopes, as you're aware. I just want to ask one more thing. This sort of pretty hefty skill set, does every bariatric surgeon need it, or do we need to identify 1 or 2 centers in every region where this sort of work could be concentrated, like complication management and advanced and endoscopic stuff? Because otherwise there's not enough volume for everybody to maintain their skill set.
No, I agree. I think, you would probably should aim to try and identify a regional unit, and then try and identify surgeons who have already got a set of skills that will assist in quick learning of the rest of the skills. Because this, the endoscopic, I mean, we only saw just a few of the procedures, but there is a lot more skill sets needed to have the skill sets like endoscopic suturing, etc., in order to build that perfect repertoire. So I think it would be quite important to identify the regional centers and then identify a few specialists, not necessarily from the same center, but from the regional areas, and have them trained for this, I suspect.
Yeah, no, it's fine, Rupa. Thank you very much. I agree. I'm just going to bring in Sonia. Sonia, with regards, I'm not suggesting by any means that you have a huge experience of managing leaks, but if you were to have any, do you have any experience of using stents or endoscopic management? Have you ever managed a leak? If so, how would you proceed? What would you recommend?
So it's my honor to be with you. Thank you for your invitation. My experience is now more than 10 years in obesity surgery, and the great thing was that I worked in a high volume center, and we did more than 1,000 surgeries a year. Could treat a lot of patients.
Excuse me, could everybody just mute themselves, please? I can't hear Sonia. Yeah, Sonia, sorry. Yeah, go ahead.
So, okay, sorry. So I have a great experience in treating leaks because we worked in a high volume center, and I worked with Rudolf Weiner and Christine Stier, and I also lived the change in treating leaks. And I remember in the beginning, more than 12 years ago, that we used the stents in sleeve leakage. And I remember how Manuel said the patients, they stayed 6 weeks and complained a lot of vomiting, pain, and so on. And then we changed our treatment to endoscopic vacuum therapy, and we did much more endoscopic treatment because we had Christine Stier who did the part of endoscopic complication management. And I have to say, this has changed importantly bariatric surgery. And when I came here to Italy more than now 2 years ago, for me, the most important thing was to have a good endoscopist, because I'm trained in bariatric endoscopy, I can do it. But here I'm performing more than 300 surgeries a year. I'm alone, so I have to concentrate myself on the surgeries. I can't do everything. So in my opinion, it's important to have a good team. You have to know how to treat the complications endoscopically, because the patients get much better in fewer time. And yeah, you have to create a good multidisciplinary team. And when you are not working in a high volume center, you need yeah, the skills, and you need an endoscopist who works with you. A good bariatric surgeon needs a good bariatric endoscopist.
Yeah, thank you very much, Sonia. So with that, we'll move on to Mohit's talk, and then Bridge can moderate the session after that.
Just before that, 20 seconds.
Yes, Manuel, please go ahead.
I might have good news for you. So send your surgeons to us, and me and Mohit, and we all together, we can train them in whatever technique you want it or you need it. Just send to us, and we will be opening the center. The center is opening to you all.
No, thank you, Manuel. And I think, I'm sure friends here would take Mohit and you up on that offer very soon. So we'll invite Mohit for his talk. But Mohit, I'm going to present, I'm going to spend 30 seconds presenting a case to you. And I'm hoping that you can cover the management of that patient in your talk.
Sure.
So somebody from the country, somewhere in the UK, called me today. I'm not allowed to say too much, but I will tell you this, that this patient had a sleeve gastrectomy in 2014 in a center, and has been having repeated left upper quadrant collections since then. This patient has definitely got a leak. They have proved the leak. It is 3 centimeters distal to the gastroesophageal junction, but it's a chronic leak going on for 7 years now. Patient has not had any further surgeries, only one surgery, that was a primary sleeve gastrectomy in 2014. Subsequently, few percutaneous drainages have been done. I'm hoping in your talk, you can at some stage also tell us how you would approach such a patient.
Yeah,
thank you.
Sure. So thank you, Kamal and the team for having me here on this show. We've been doing a great job, and it's an honor to speak here and contribute to, a large amount of work which you have already done, spreading the science of bariatric surgery and obviously now bariatric endoscopy. So I'm supposed to talk on endoscopic management of sleeve, and obviously this is my university, my center, and my biggest disclosure today is that I've worked with Professor Manuel Galvao Neto, is my teacher and now joined my center. Dr. Phoebe, I've worked with Dr. Phoebe, is still there with me, but now mentoring me virtually, because these are the days he is not traveling much, but we are doing virtual bariatric universities and a couple of other academic activities with him. I'm a advisor also to Apollo Endosurgery and Pentex and Olympus, and recently me and Manuel signed a contract with Fusionon to start Fusionon Academy, or Fusionon Gurukul, which will train bariatric surgeons in bariatric endoscopy, and that's why Manuel was making that offer. So he will be there a couple of days in a month in India to train these surgeons, so anybody from the world can come. Apart from these, I have no other disclosures. We have done close to 15,000 bariatric procedures, and as you can see, more than 200 endoscopic sleeves performed at Indore. But we have pretty much experience with all the kinds of procedures. You talk about sleeves, gastric bypasses, or one anastomosis, everything has been done. But the point is that having performed 4,000, 5,000 sleeve gastrectomies, what we realized that sleeve gastrectomy, the Achilles heel of sleeve gastrectomy is leaks and fistulas, and surgery is so simple, and but it is not so simple. Most surgeons would do it on the name of resecting a part of the greater curvature, and they end up having complications. And because it is the most commonly performed procedure across the world, that's the reason why we have such high rate of complications with sleeves. So I would say the two problems with sleeve gastrectomies, one is a leak and the other is weight recidivism. And the reason why the procedure being so popular is still being challenged by the old stalwarts of bariatric surgery and still it's not the answer to all the problems on this earth, is because of these two problems, leaks and weight recidivism. The incidence of leak in the sleeve gastrectomy has been reported, and it's in different literature. So it can occur from, so most literature report 1 to 2%, and if we talk about fistulas, it's 0.2 to 2.5%. That's what is reported in literature. But the problem is that despite 2%, or let's imagine at max 2.5% of these leaks and fistulas, because it's the most commonly performed bariatric procedure across the globe, this number is very high. And apart from the leaks, we have stenosis, because the stenosis will eventually lead to a leak. So this is a very common scenario, and we know that most of the surgeons, and in fact, I was in the operating room with Manuel, and I was telling Manuel what mistakes surgeons do, and that's why we need the help of a bariatric endoscopist. And we exactly realized that the narrowing at the incisura, and I have seen most surgeons, they do not realize that what we are seeing in laparoscopy is a very enlarged view. So even if you think that you are 1 to 1.5 centimeters away on the laparoscopic view from the incisura, you are actually not. You may still have created a stenosis which looks like patent to you on the laparoscopic image. So a word of caution there, and this stenosis often leads to leaks because there's already a high pressure system, and then you further create a stenosis, and that area of GE junction, which is pretty weak, it leaks. We don't know the causes, but as I said, tissue ischemia, the staple line, tissue thickness, blood supply, a lot of things which are responsible for the leaks. Now, how do we approach? So one of the cases with Dr. Mahawar discusses a very chronic old leak, but let's talk about acute leaks. So we get abdominal pain, fever, tachycardia. You need to assess the patient, and what Professor Phoebe taught me, and over a period of 15 years of this bariatric surgical practice, we realized that the patient would not look good, and we should always have a cutoff where upon that threshold, if the pulse rate rises or the urine output decreases, or we have parameters dropping down, we should have a very low threshold of putting in a scope and seeing whether it's the leak or what has happened. The radiology services are very important because we see that a CT scan can detect leak very early. But even if we do find a CT normal after doing a diastole, but there is a suspicion with clinically a very low threshold to put in a scope and check if it's a leak. So what is a treatment? So I would say that let me cover the part of what Dr. Mahawar said into this. So there are early leaks and late leaks, and this is, I don't want to make it very complicated, but for those who are listening to it, any leak which is less than a week and any leak which is more than a week. So there are two different views on it. So if I supposedly as a surgeon get a leak which is less than a week's time, mostly picked up in a hospital, I end up converting them into Roux-en-Y gastric bypasses. But it would depend upon the kind of expertise you have, how many gastric bypasses you have done, and what sort of infrastructure and support you have. But the most easiest way to deal with this is a totally covered stent, which is around 45 centimeters in length. It starts from mid of the esophagus and goes up to the first part of the duodenum, and that's a totally covered stent. And that stent, along with good lavage and a feeding jejunostomy, can solve the problems. And this stent should not be there and should not be kept for more than 3 weeks, I would say. The moment we go beyond 4 weeks, it causes a lot of stricture. It's very difficult to remove this stent. It's a totally covered stent. So very simple, early leaks, if you have the expertise, within the hospital setting, you detected a leak, go and convert it into a Roux-en-Y gastric bypass, and you can start liquids depending upon the kind of tissue you have, and you can discharge the patient. If it's a late leak beyond 1 week, I would not recommend to go ahead and in that sort of a situation, such a stormy situation, but then put in a totally covered stent, do a feeding jejunostomy, and think about the nutrition. So this is what you find when you do a diagnostic laparoscopy. This is a sleeve leak. We went in with a diagnostic laparoscope. So what somebody should do in this particular situation: no surgery, no gastric bypass. A very interesting article by one of the Indian surgeons bypassing the these stents by doing a gastric bypass and sleeve leaks, but this is not a situation where you're going to go and do a gastric bypass. The thing what all of us should do, go there, do a lot of lavage, and this was, mind you, a banded sleeve, so we have to remove the band, no foreign body there, remove the band, go do a lot of lavage, and then put in a stent. So I tried a primary repair, but it did not work. And I knew that it was not going to work, but then we deployed a stent in the same sitting, and we did a feeding jejunostomy, and this patient did pretty well. So this is a totally covered stent, and this is an ET stent which we used. It starts from mid esophagus, goes up to the first part of the duodenum, causes a little bit of bile reflux for the first 48 hours and a little bit of pain. But with the kind of management we have these days, and as you can see the stent, the X-ray, so this is good. And then obviously a lot of lavage, 2 drains, feeding jejunostomy, and you can discharge patient within 48 hours. So this is, I'm trying to keep it pretty simple. The fibrin glues, I don't believe in them. I don't think they work. Manuel already said they are just mentioned here to be condemned. We have never seen fibrin glue working in our own setting. They might work, but again, I think I'm more dependent on a totally covered stent to treat my leaks, which are late in nature, and early leaks, as I said, a gastric bypass. So I'm not. These are the publications for the stents. But as I said, a totally covered stent is something which is pretty much required in these particular circumstances. Also, some surgeons would go ahead, and if there's a stricture there, they would do a dilatation with the balloon, and then they would drain the sleeve leak out to a gastrostomy and into the fistula, and that's what Manuel does. He dilates most of these strictures, and then we'll do a gastrostomy with a pigtail into the major pool of collection in the fistula, and that can be then drained out. So that's also another way, create a low pressure zone and drain it out. That's another way of doing it. But this is the complication, which like some complications which like Dr. Mahavar also mentioned, the post sleeve chronic fistula. So this is even despite, in this particular case, we put in a stent, it healed after a stent, but then after 6 years, patient came up with fistula, and then these late fistulas after 6 years, we usually go and manage them with endoscopic suturing. So as you can see, we had this fistula, and we manage that using endoscopic suturing system. So we first gave some energy sources to that area so that we have a good sort of fibrotic area to take sutures and create fibrosis, and then we repaired the fistula using the endoscopic suturing system. So that's a chronic 6 years old fistula. If this thing does not work, as Dr. Mahavar mentioned in their patient, that very old fistula, and you're not able to work, my option in that particular case is period an esophago-ruovi jejunostomy, because that's the only option left with you at that particular stage. So to answer the question, very early leaks, if you have the expertise, go ahead and do a gastric bypass in the hospital setting. A leak greater than a year, greater than a week, pardon me, should be managed by lavage, totally covered stent and feeding jejunostomy, and discharge the patient, and then remove the stent. Don't keep it for more than 3 weeks. And leaks like this, and which Dr. Mahavar is mentioning, multiple surgeries, persistent, you can go ahead, do a suture. And if this does not work, absolutely my indication would be to do a ruovi esophagojejunostomy. Dr. Phoebe hates that because he says it causes all the weight regain. But we have tried everything. The stent did not work. There was no option of a surgical conversion to a bypass. We tried endoscopic suturing, and then finally, if we do not have that, we have to do a ruovi esophagojejunostomy. That surgery will cause a complete weight regain, and we have done that in our setting. There's a lot of weight regain which happens, and the patient, and so what Dr. Phoebe says that, Manuel and Dr. Phoebe, my two mentors. So you have at one end, Dr. Phoebe would say that you are putting patient through such a big problem, and then you finally end up giving him a complete weight regain. So first try stents, try endoscopic suturing, and then if nothing works, then you can do. Again, stenosis, just some last slides on that. As I said, balloon dilatation is one way, and it requires multiple settings of dilatation. And you know, this is a CT scan of a twisted sleeves, and these kind of sleeves, they're more prone to leaks. Sometimes there are no leaks, but then these kind of sleeves would not cause leak, but they cause a lot of vomiting, GERD, and all those issues. And you know, the ultimate solution I have is to convert them into a roux-en-y gastric bypass, absolutely, because that's a treatment for patients who have continuous vomiting with twisted sleeves, and you give a permanent solution to the patient. We have endoluminal strategy, pneumatic dilatation, stricturoplasty, and stents, which obviously bariatric endoscopists would prefer. But in my own setting, I'm more confident by managing sleeve stenosis without a leak, mind you, sleeve stenosis without a leak, by converting them into a roux-en-y gastric bypass. But we are talking about bariatric endoscopy, so pneumatic dilatation works, but multiple settings are required and works beautifully. And you know, that's something which can be offered to patients who do not want a surgery, or centers who are not that good with gastric bypass as an approach. Again, I would say ecclesia balloon is something which all bariatric surgeons should have in their clinic, because this is a very high pressure balloon, and these are mostly used for cardiomyotomies and POEMs, but they are the one which causes good amount of dilatation, and they are effective if you have a stricture with a stent. There are separate pneumatic dilators which are used for sleeve strictures. They are not this one, but they are separate because this can blow out the sleeve. But this is these are specifically used if you have a stricture post stent more than 4 weeks at the esophagus or somewhere at the level of the sleeve. But for the dilators which we use for sleeve strictures, they are different pneumatic dilators, and then they have to be done for at least 3 to 4 settings before we achieve the results. So I think this is one last video. I would say this was a sleeve stricture, and now this sort of a picture we get when we put the stent, the nitty stent, the totally cover stent for more than 4 weeks. So this patient did not turn up, and this is what you get. That's why I've put this video here. So even if you're using a stent, it's not free of complications. You can have these strictures, and then these strictures will have to be dilated by a balloon, and several settings of dilatation have to be done. So don't keep your stent for more than 3 weeks. I would say 4 weeks is the maximum, and if that period, the patients will have definitely will have healing of the leaks. And this is the case where we put a stent for 6 weeks and we had these sort of problems. So I think I'll stop here. I'll wait. You know, I'll conclude here. I want more questions. So I won't keep on, because Manuel already has shown a lot of videos. So you know, the take home message would be that leaks are common because sleeves are the most commonly performed procedures. Very simple for those who are watching. Young surgeons who are doing, they should have one covered stent in the start of their practice. So I always keep 2 covered stents with me. They are not available in India very frequently. Keep them. If you have an early leak in the hospital setting, you don't know how to do a gastric bypass, or you're not confident enough, call another surgeon. He can convert it for you if he feels that the tissue is good. Keep a very low index of suspicion. Put in a scope if you feel anything which is wrong. There's no harm in putting in a scope, even if the CT scans are normal and you feel the patient is not doing good. Don't go in a denial mode. Leaks are very common, and if there's tachycardia, high blood cell count, and the patient is not feeling good, go and put in a scope, explain the attenders. It can be a negative diagnostic laparoscopy. Put in a totally covered stent. You should learn how to put in a stent. Do not keep it for more than 3 to 4 weeks. And if the patient comes with a very chronic leak, like 6, 7, 8, 10 years, you can try endoscopic suturing. It works only in 10 to 15% of cases, and you may have to do 2 or 3 sessions of endoscopic suturing if one does not work. But the final solution is a roux-en-y esophago gynostomy if nothing works. So thank you very much. This is an old photograph. Now we have Manuel have shown you our new photograph of a new bariatric endoscopy team. So thank you very much, Professor Kamal, for inviting me, and I would be more than happy to have the questions.
Mohit, that was a brilliant talk. Thank you so much. It was really very informative for all of us. Mohit, if I can ask you a few questions that are in the chat box. So one was, is there any role of using the VAC, endoscopic VAC or vacuum device following a sleeve gastrectomy leak, or the endosponge as it is called? Any experience with that, please?
I think Manuel should answer. What I do is stents and gastric bypass, but the one who has used it, so Manuel has used VAC therapy. He should answer that question.
Yeah,
Sure.
Manuel, if you could please.
It's very interesting to see how it's going in Europe, and I'm watching very closely, and I don't like what I see because it's a completely overkill. You know how I can use a cannon to kill an ant? That's what they're using. So you're going to keep the patient in the hospital for 10 days in a leak that you can treat by stent or even more. You can use just most of the cases now, we are using the double pigtail and just send the patient home in 5 days, so comfortable, not even having any discomfort with the stent. Remember, my dear friend in Europe, dear friends in Europe, because I'm seeing that so much, this EVAC endosponge, this was developed for catastrophes in mediastinum, in the lower rectum. And what you have is a patient that's not septic. Patient can go home with a lot of stuff. So it works good. You have no access to technology. You have no endoscopies. So you yourself can just put the sponge down and go like that. There is some new ways to do that. So the first endosponge that you have to exchange every 3 days, and the patient have to do a lot of time and stuff, you don't use anymore. So what you use now, you put at the level what you see the hole, you put 4x4 gauze, you put a 3M plastic dressing, you multi-perforate that, then you put on the level, then you pass another tube inside or use a three-way so you can feed your patient. And with that, you have to replace it every 7 days to 10 days with something that we had developed in Brazil, a friend of us called Dr. Flaubert, and is doing very good, cheap, easier, and you can let for more days. Again, I have nothing against, but it's a huge overkill that I don't know why people are using that on sleeve gastrectomies. Sorry.
I think, Manuel, I have a point to make here. I think it's why we are complicating. I absolutely agree with you. We have such a simple therapy, and we have such a simple stent. And let me tell you, we can easily train bariatric surgeons to put that stent. I mean, it's not a difficult thing. And I don't know why. I have no, and feeding jejunostomy is something which all of us, in any case, you have to go inside and do lavage and clean and put drains. So why not follow a very simple way? Go inside with an endoscope, do an endoscopy, put in a stent in the same sitting, do a lot of lavage, put drains, do a feeding jejunostomy to provide patient with nutrition, and come out. I mean, what's the big deal in creating multiple therapies and creating problems? That's going to confuse people more. I mean, I don't know.
Okay.
I would say
have you guys used it? Have any of you have used in a patient an EVAC or endosponge?
So I'm going to ask that question too, Sonia. Yeah, there you go. She's raising her hand.
She's not happy.
So, yeah. Well, she's
No.
smiling. She's smiling.
You are great friends. I respect you so much. I am your follower, but I have to. I disagree. I'm sorry, because as I said before,
You're Germany. You're Germany.
Yeah, I'm Europe, Germany, Italy. So I'm Europe.
Yeah, but you come from Germany, from the land of these things.
Don't say them anything. I'm in their place now. So we have
to keep Mohit safe in Barcelona. Yeah.
You're near to me.
I know that.
So, Sonia, why
I have to. It's my experience. So when I started 12 years ago with Rudolf Weiner, we posted stents in every leakage. Yeah, we did abdominal drain, diagnostic laparoscopy, abdominal drain, lavage, and then we put the stent. And these patients had pain, reflux, important reflux for 3 weeks. In this time, we let them also stay in for 6 weeks. The stents dislocated. We had stents in stents. We had stenosis after, you showed it. We had the ulcerations. So these patients were really hard to treat. Then we had this area of changing where the esosponge come. And I have to say, we had a lot of patients which we treated. Obviously, we had to change every 3 days the esosponge, but we had our own endoscopy. It takes 10 minutes if you can do it. And we saved life with this treatment. And so we had a new approach. And when I came here in Italy, I also started the first leak to treat with the esosponge. And there was an endoscopist who has a lot of experience with the pigtails. And so we now are doing pigtails in these patients. And when the patients come in the emergency and they do not have a sepsis, and in the CT scan, you see that they have a small abscess due to the leakage, you can also manage them only with the pigtail treatment, only with the endoscopic treatment. Obviously, if the patient comes in sepsis and so on, you have to do a laparoscopic surgery to train, to lavage, to train. But I don't use stents now since.
So you agree with us?
I'm sorry?
You agree with us? You are using stents. Pigtail is a stent.
Don't use stents.
Pigtail is a stent. Pigtail is a self-expandable stent.
Yeah, because pigtail is put distal to the obstruction, so it's like a stent. I mean, you put distal to the stenosis, it's a stent.
No. What we agree is that sponge be an overkill.
So in the degree, so we are friends. This has to be used in really hard cases. These are life salvage cases where the surgeon does not know what to do anymore, and you are really in the disaster.
Agreed. 100% agreed.
So we agree.
So,
but
Sonia,
I have to say, at the end, when I came here, I ordered the stents. I have never used it in the last 2.5 years.
Because you never had a leak.
God bless.
No. I have leaks, and there another important thing is, which you said, poorly. I see a lot of leaks here in my country due to twisted sleeves, due to stenosis in the incisura. So the most important thing to prevent leakage is a good surgery. And when you do the first cut versus the incisura angularis, you have the stenosis and you get the leak. So in this case, how you said, in my opinion, also a conversion to gastric bypass is the only way to treat. Yeah, when you have a twisted stenotic sleeve. But
so Kamal, I treated a similar patient like you mentioned. She is a lady operated in the army hospital, and it was a 15 years old leak. 15 years. Okay. I did a Roux-en-Y esophagogynostomy. They're doing very well. You basically go into a plane which is virgin, because that area, you open the esophagus, bring around 4 centimeters down, disconnect it completely, use an Orwell device, and you work in a virgin zone. So it's an easy procedure.
So
I don't. Yeah.
Mohit, when you say esophagogynostomy, do you transect above esophagus, above the leak?
Yes, absolutely. You're gonna mobilize. You're gonna open the hiatus, mobilize at least 4 to 6 centimeters of the esophagus, pull it down, transect it above the leak, and then what you're gonna do is push in a bougie and use an Orwell device. So I can do a hand swing esophagogynostomy if I get a good length, and that I can do a 98% of the times. I did it like 10 days back in a case, similar, like 4 or 5 years leak, which came to me from other center. But we can use an Orwell device beautifully, make a rule loop, go up, and it's easy.
So just using a serosal patch of jejunum wouldn't work, just like
No, absolutely not. Absolutely not. If you have tried everything, see, these are the things you do initially. If you have a failed stent, you have failed pigtails, you have failed VAC therapy, or I'm not against any therapy, but once you have failed everything, even endoscopic suturing sometimes can work, chronic, very chronic. But if you have failed all this, I would say go ahead and do it, because you save a life. The only thing which Professor Phoebe says, and now I agree because I have data on that from my own center, they gain a lot of weight. They gain all the weight. Some of
I think patients like this, they're generally after their life rather than wait at the moment.
Yes.
I'll hand over to Bridge again. Sorry, Bridge.
Yeah, no. That I think that was good discussion. And I think there are a few more questions. I think I know I'm conscious we are slightly running over the time, but there are some interesting questions. So if I can ask the panel that question. So Mohit, there was one question about the frequency of dilatation. You mentioned about dilating the sleeve.
Yeah.
Is there any particular time frame when we should dilate, or it's more clinical?
So we have had instances when we have to do 4 or 5 dilatations every week, but still it did not work, because it worked for sometimes, and again patient starts to have vomiting. It works in 20 to 30% of cases, and if not, then we have to.
I can tell you this. This is how biased you are. So Mohit cases are biased because he received very late cases. When you have a helical stenosis with more than 6 months, it means that the helical stenosis is here, and all of this tissue here, it quits. It's dead. The muscle is dead. So it doesn't matter, you fix the stenosis, and then it turns again, and it's dead. In that case, this is completely right, 30%. If you get that, or as I get more early, it means that patients come to me at 8 weeks.
8 weeks.
8 weeks or more. That's how you have a window of opportunity with 80 to 90%. So depending on how late you come, because as much time it passes, and believe me, when you do a total gastrectomy, in cases like that, the stomach's like this small. It's completely turned, twisted, and like this. Doesn't matter how much you dilate, you go. So you have to get it in a window of opportunity. So like the surgeons can keep the patient with stenosis for up to 3 months. They always liquid diet, pure diet, but they never go to solid diet. That's how they come to me. When they come to Mohit, they are referral cases with 2 years.
3 years, 4 years.
So that you always, it doesn't hurt to try endoscopy. It doesn't hurt. Try it. Maybe you can find 20% is good. You save a stomach. But this is very interesting how the same topic can be seen from 20% success rate to 80, 90%. And everybody treats us the same, that it is not. So I hope I can get some light on this turmoil.
Sure. Rupa, could I ask you to come in there? Any experience with stenosis post-sleeve, and have you used any of the techniques that we have been talking about?
I haven't had any personal experience, but within the department, I have seen, stricture or stenosis after, in fact, not after sleeve, but after Roux-en-Y gastric bypass and the anastomosis. And most of them have been treated with endoscopic dilatation. I've also seen patients who have then had perforations following that and has had to redo surgeries. So it can be as straightforward as just dilatation and resolving all, resolution of all symptoms. But at the same time, you do come across from time to time patients where they end up with further complications from one to the other.
Yeah, no, I agree. I think it depends what the patient requires, and sometimes it's multimodal treatment. There's one more question. I think, Sonia, if I could ask you that there's a question from the attendees that do you dilate the sleeve at the time of pigtail insertion routinely?
No.
No.
We do always an upper endoscopy, obviously, to see if it's twisted or if there's a stenosis. But it depends. Obviously, if you have a stenosis, I think if you have a really important stenosis, in this case, the stent treatment could be also better. But the last cases I treated, I never dilatated.
Okay. Okay.
If I might add, the French school where the pigtails came from, our dear friend Gianfranco Donatelli, he only pulled pigtail stents as much as he can. He doesn't care about stenosis. Now, very recently, we get an agreement. As pigtails can be placed very early, it's not advisable to do pneumatic dilation because it's very fresh. It can have perforations. So leave your pigtail there, then evaluate after 1 month. This is where we start doing the dilations, 4 weeks, and then you can dilate, and you can easily dilate over the pigtail line. The problem is that sometimes the pigtail can get out, so you pass another one. So that's not a big deal on that. So what we do here is that we put the pigtail stent, then we evaluate after 1 month, and if you see helical stenosis or axis deviation, we do a dilation, and if the stent get out, we put another one there. So that's how we do that. But the French school, that is what Sonja follows. Now it's the Italian school, that's Sonja's school, is that just to do the pigtail, and you're going to have a very high resolution, and patients going to be so happy, especially if you do like Mohit and you do a jejunostomy. So problem with pigtails, let me tell you guys, it's a big problem. You're not going to remember the patient not going to remember you. Cool. Yeah, good.
Yeah.
I have a question for
Yeah,
both
Rupa,
of
go
our
on, yeah.
presenters. So I know you mentioned about the NITI stent, Mohit. So do you normally do any fixation for these stents? Because obviously all these stents are quite prone to migration, aren't they?
Never. This is a stent which never migrates. It has a migration rate of, see, I'll tell you, all these stents, I have used a lot of stents, but a totally covered NITI stent never ever migrates because it starts from the mid esophagus and goes to the first part of the duodenum. Never I have taken a stitch and it never migrates. Manuel, you can throw light on that.
If I can add, your stents don't because you follow your patients. But there is some schools that put the patients and put the stent and send the patients home, never gonna see them. So remember, just like to the French school, they published last year 5 cases of aorta perforations with those stents. And I thought that I called them, I read the paper, and those patients, they have no follow-up. So this is it's a weapon. So you have to, as you do, and I know how you do it. You follow your patients very close. So these patients can do a lot of harm. They can dislodge, but if they are not using in the right way as you use it. So a lot of people don't use the way we use Mohit. They just put the stent and send the patient home. They have this sexual fetish that the patient with stent can go home in return to be removed, and that they don't know where they come from. They can eat solid food. They're gonna have a good life. They don't gonna have a good life. Stents are evil, but they're nice. But just follow them.
I have this experience that I absolutely agree with you, man. I think we should call them back at 3 weeks and remove it at the most 4 weeks, because the moment you go beyond 4 weeks, you will end up with what Manuel is saying. First, there will be a stricture, and then they can perforate and all those complications. The question which Rupa asked was specifically, I think she wanted to know whether the stent can go into the duodenum and thereby, I think NITI is a covered stent and it's a very long stent. It does not migrate.
Yeah, it's a heavy stent. The suture is not going to hold.
And the suture will not hold.
Which is the reason?
Esophageal stents, they hold. But
Yeah,
this big stent, they cannot hold. It's too heavy.
no, that was the reason for me asking the question, because obviously the literature is quite divided into what you should do. There's no good evidence for either way. But the reason I asked you the question was because we recently had to insert a stent in one of the patients in the department, and the stent had migrated from mid-esophagus to just above the GOJ. So it was barely covering the leak in about a week to 10 days time. And we were contemplating whether to pull this up again or to just leave it behind, or what to do at that point.
Yeah, Rupa, if I can add, there is another thing that lots of people not understand about stents. So your 24 centimeter stents actually is a 19 centimeters. So when you put that inside, you're gonna have 24. And as they expand, the tips go like this, so they shortening.
Yeah,
they're really shortening. So you have to plan ahead how much shortening. You should expect 2 or 3 centimeters shortening on the upper part and the lower part. And that is very interesting because you have to put it a little bit ahead of what you're thinking, and they shrink. And most of them, I see, is that they didn't dislodge. Is that because they shrink because they open? So there's a lot of physics on that, and people just disregard that.
I think 4 centimeters is a very good margin. 4 to 5 centimeters. You should cover above that, and below should be the guide wire should be placed in the first part of the duodenum. This is, if we do that, usually I have not seen. But as Manuel said, you can't take a suture on this stent. It's a heavy stent. It won't stay there.
And you know what I'm thinking? I'm thinking at some stage we have to invite you guys back and show us the types of stents that you use. Just take us through the technique part of it, and maybe just show it to the detailed videos of the whole technique. I think that is a challenge for us to organize at some stage.
So Kamal, me and Manuel, we are preparing a course, specifically a course for young surgeons, and everybody wants to learn.
Not old people like me, Mohit, then?
So you don't have leaks,
Good comeback, mate.
You're young here and here, so that's what's important.
So we are preparing a specific course only to manage sleeve leaks. And that's a hands-on course. So we're going to talk about leaks, we're going to talk about strictures, stenosis.
So maybe we could think of relaying it to TUGS audience as well.
Absolutely, absolutely. And
or I will be in touch with you.
We can train them how to put a stent without, how to put a pigtail, and we will have models to train them.
Fine, Mohit. So Bridge or I will take this conversation forward with you after this event. I think this is something could be very useful. We all need to learn how to use stents and know better than you two to show it to us.
Because surgeons, and Sonia agrees with me, because in her practice, because she was with Dr. Weiner and they had a huge volume, so she was trained. But I know a lot of surgeons, they don't do endoscopy, and then they are dependent. So I think in our fraternity we should learn bariatric endoscopy. It's not only for weight loss, it's to protect ourselves.
We should free the surgeons. We should give the surgeon access to the endoscope. That's our mission.
Absolutely.
It's a tool.
It is like an insurance.
I think I can see a comment from Aya here. A video of the pigtail would be useful, as we do not commonly do this in the UK. I agree, Aya. We need sort of a training session, covering videos of how you do it, just teaching us the equipment as well. So maybe some sort of a training session would be useful. Well, thank you. Over to you, Bridge.
Yeah, no, that's fine, Kamal. I completely agree. So we'll probably have to invite Professor Manuel and Mohit again at some point to show us the technical side of things. There are 1 or 2 more questions, but I'm conscious that we are running way over time. And as we already decided that we'll have another session on bariatric endoscopy, I'm sure there is a lot of things to learn from both of them. So I think if I may take the opportunity to conclude the meeting today, Manuel and Mohit, thank you so much for your talks. It was an eye opener for us. I'm sure all of the attendees have learned a lot. I personally have learned a lot from you. So thank you so much. Sonia, thank you so much for coming tonight. It was a pleasure to have you. Rupa, thank you so much. It was lovely to see you after so many years. And I'm sure we'll have more sessions like this. Kamal, thank you so much for moderating. It was a pleasure.
Thank you, Bridget. It was a pleasure. And thank you, Manuel, Mohit, Sonia, Rupa, everybody, and everybody who's attending as well. Thank you. You are the reason why TUGS is successful.
Yes,
thank you.
Perfect. Yeah. Thank you so much, everybody. Good night.
Bye-bye.
Thank you.
Good night.
Bye. Bridge, I think another good session. We need to sort of link up with Mohit and maybe sort of stream some sort of a teaching session on
I think
stents and
so.
all.
Yeah. I mean, I
Yeah.
presume the course he's mentioning is probably in India. He's hosting.
Yeah, I mean, if
Or
it is
will it
live
be-
streaming, we could also stream it on some, I don't know, we'll have to work it out, isn't it?
You know what? I've spoken to Sanjay about the lips, and I was going to talk to you about that one. Last year, there was no session on bariatric endoscopy, and I was hoping we could suggest one on that. What
Well,
do you
that's a
think?
good idea, but wouldn't it? I think that's absolutely no-brainer, really. I mean,
Isn't
look,
it?
as Rupa was saying, we all need to know a little bit about it.
Yeah.
And look, these are rare events, and that is why none of us take any interest in it. But when they happen to us,
When they
that's
happen,
when we
it's,
realize.
yeah. I
we
mean,
will
like the one you mentioned, it's a nightmare when it happens. You won't know
Yeah,
what to do.
and I was only phoned today about this
Yeah.
from somewhere, and I said to the colleague, I said, look, my heart goes out to this patient, and
Yeah,
obviously, you are in
yeah.
a difficult spot managing this.
Yeah.
And obviously,
yeah.
Gentlemen, sorry to interrupt the conversation. I don't know if you can hear me or not.
no,
We
we
can.
can. Hello.
Great. We haven't met. We haven't had the pleasure of meeting. My name is Devinder Bansi. I'm a consultant gastroenterologist, Imperial College in London.
Hello,
And,
Hi,
Devinder.
Devinder. Hello.
Hi.
Thank you for joining us.
No, it's a pleasure. I was very pleased to join the meeting, actually. You're quite right. I mean, one of the moderators and commentators on the meeting from Italy, she said something like every good bariatric surgeon should have a good bariatric endoscopist working alongside them. And historically, UK endoscopy has really fallen way behind the rest of the world when it comes to bariatric support services. And at Imperial, you probably know Ahmed, who works with me at Imperial.
Yeah.
So Ahmed's the head of
We have
our...
a few friends at Imperial, Devinder. You probably know Sanjay as well.
Exactly. Sanjay Purkayastha and Ahmed, and I know a few. So I've been charged with writing up some endoscopic interventional guidelines for bombs, which we're hoping to get out very soon. And we're also in the process of writing the BSG, British Society for Gastroenterology, endoscopic guidelines for bariatric endoscopy, which is a collaborative piece of work between about 5 or 6 of us. So, there is an appetite for this kind of work. But the other critical point is it's about volume as well, about volume of cases. And everyone's doing a little bit here and there, which is all very, admirable, but it's not going to take us very far. We need to work together on a lot of these different subjects.
If you heard earlier, this is exactly what Rupa and I were talking about, that, I mean, thankfully and luckily, many of us would see a leak or two in our careers, and I didn't want to boast about it earlier, but, I am now doing bariatric surgery for nearly 13 years, 10 as a consultant, and I'm yet to see a leak. So see, I mean, again, I'm sure it will happen one day. It could happen next month. It could happen tomorrow. And then I will really feel out of depth. So we need a mechanism of looking after these patients, at a central level, sort of.
Yeah, no, I completely agree. And that's why things are moving slowly. And I think meetings like this highlighting the issues and the deficiencies that exist in the service that we provide are really invaluable. So I just wanted to congratulate you both for setting up an excellent meeting. Thank you.
It's all Bridget's brainchild, Devinder. I'm making a guest appearance, but thank you for joining.
No, Devinder, thank you so much for joining. And I wouldn't trust what Kamal is saying. I think it was his idea, and it's all our team effort. So thank you so much. Really appreciate what you're saying. So look forward to reading those guidelines. I think that will be quite
and
helpful.
if we could help in any way, just let us know, please, Bridge. I'll share my email ID here, and we'll link in. I think you probably obviously Emma is on the council and I'm on the council as well at BOMS, so we could work multiple ways.
Yeah. No, I'd love to. That would be very helpful. Thank you.
Yeah.
Well, look, I'll leave you both. Have a good evening. Thank you.
Thank you, Devinder. Thank you so much. Take care.
Bye.
Thanks.
Bye.
Rupa, how's it going?
It's good. Just been busy with various things.
It's funny that we get to meet on a Zoom platform.
I know. And with no bombs last year, then obviously the one place where we all meet together.
Are you going to August in Belfast?
This year, no.
Yeah, October next month. No.
Yeah, no, I'm not able to at the moment. I'm on call. We do 2 weeks of on call, so it's been a bit difficult to swap that. But hopefully next year, definitely.
I missed BOMS for the same reason. I think I was going to go to BOMS, the earlier one, that was in first week of July.
Yeah.
I'd all made plans to go to Oxford, but then when it got moved to the last week, then I couldn't because I was doing nights and it was just too short notice and nobody was talking to me. But I'm hoping to go to Belfast. I think Bridge is going there as well. So.
But that has been the problem, isn't it, with people being up sick and everything. You can't swap your on calls very sure.
It's so difficult to swap on calls. I mean, I think all of us have at least 3 or 4 surgeons on call at any given time.
Yes.
Day, night, dual.
We've got the same, day and night. We're doing too many on calls now. I think there are hardly times when I'm not on call, really.
I know. I feel the same. It feels like you never get a moment, never get a week where you're not on call.
Exactly. Yeah. Likewise. Likewise.
I've booked my flights to go to Belfast now. I booked my study leave, so it's just the
hotel.
Excellent. I was going to speak to Bridge and then find out where he's staying. Obviously, he's staying in too posh.
No. I've not booked anything. I've just booked study leave, and I have to book everything now.
It's a nice 5-star hotel just next to the conference when it's not too expensive, Bridge. So
Not too expensive, 5-star.
It's not too expensive. No, it's not too. Nothing for you anyway. So I'll share the details with you.
Completely believe you. Yeah.
I think I'm going to reach there on the on the 11th. Is it the conference is 12th, 13th, 14th? Well,
yeah.
I'm reaching
13th, 14th, 15th.